Hi, this is Dr. A. We're going to look at clinical chemistry considerations for the pediatric patient, and we're going to just do a review of our physiology and how it applies in lab testing. Okay, so let's start with normal changes in the neonate. So respiration and circulation. With birth, there's the initiation of active respiration. And that requires stimuli and the surfactant present in the lungs. So the role of the surfactant is to keep the lungs basically from collapsing back down when the baby breathes out. And the stimuli, sometimes you see them smacking the baby or whatever, making it mad so that it takes its first gulp of air and inflates their lungs and stuff. And once there is air in the lungs, then you have pulmonary blood flow that will increase, and the blood pressure in the lungs decreases at birth. So what's happening is in the fetus, their oxygenation is coming from the placenta, and so the circulation to the lungs is limited, and so you have a couple of adaptations within a fetus. So you have the foramen ovale, which is here between the two atria, and then you have the ductus arteriosus also. And so what happens is on the right side of the heart where the blood is coming, so it's mixed venous and arterial blood because part of the arterial blood, oxygenated blood, is coming from the placenta here. And so it's entering the right side of the heart, and normally that would be pumped to the lungs, but there's nothing going on in the lungs because there's fluids in the lungs, and so it has these two bypasses, and you can go from the right side of the heart straight back to the left side of the heart and be pumped back out to the rest of the body. Or if it enters here the pulmonary trunk, then it's connected to the aorta, and it can actually go bypass from the pulmonary trunk instead of going to the lungs, and goes straight to the aorta and to the rest of the body. And so when the baby is born, now all of a sudden there is air in the lungs, the pressure in the lung circulation, the pulmonary circulation has decreased, and so now the blood can flow, sorry, I'm losing my cursor, can flow to the lungs, and so this ductus arteriosus here is going to close, and the foramen ovale is going to close, and so these will start closing within 15 to 20 minutes after birth, but some of them can take up to a year to fully close, especially the foramen ovale and stuff. There's also a ductus venosus, which has to do with the connection from the umbilical cord and stuff into the circulation that enters the liver. Other normal changes in the neonate for growth. So a normal baby delivered at term weighs about 3.2 kilograms. Again, about double that if you want to see what it is in pounds. The newborns will gain 6 grams per day once feeding is initiated. Although at the beginning they may actually, in the first few days initially, lose some weight as they figure out feeding, but then it starts to increase again, and their body weight will double in 4 to 6 months. Most organs are not fully developed at birth. So for example, the glomerular filtration rate of the kidneys and the renal tubular function mature during the first year of life, and the liver function can take 2 to 3 months to fully mature also. So some of the problems of prematurity and immaturity are going to be respiratory distress, where they are not making enough surfactant to keep their lungs open up. Electrolyte and water imbalances, again, since the kidneys aren't working fully yet, and then jaundice because the liver is not working fully yet. So a little bit more on prematurity and lung development. Again, so surfactant is required for the lungs to expand, and therefore the transfer of blood gases, oxygen and carbon dioxide across that membrane after delivery, so it can go from the lungs into the capillary circulation and then back to the heart, etc. The immaturity of the surfactant system is usually as a result of prematurity or intrauterine growth retardation, would result then in respiratory distress syndrome when the baby is born. So before the baby is born, you can test usually the amniotic fluid, looking for the relative amounts of lecithin and sphingomyelin, so the LS ratio, and so that is an indication of surfactant production. That is a classic test for that, and then that will assess then fetal lung maturity to make sure that the baby's lungs are mature enough to deliver. And this is not obviously a concern for a full-term infant. It would be more a concern if a woman's going into premature labor. There is a newer test called a fetal fibronectin. It predicts the risk of premature delivery. It is a protein that's secreted uniquely by the fetus and is secreted towards term or when preterm labor is potentially imminent. So that's a quick test, and that one does not require amniotic fluid. It's just a swab of the cervix and stuff from the mom. So we're going to look at regulation of blood gases and pH in neonates and infants. So oxygen and carbon dioxide measurements can be done by non-invasive transcutaneous monitoring. So this is an example here. This is obviously an adult hand, but there are some of these devices here can be put on infant heels or stuff like that, and they can use those to monitor without having to do blood gases and stuff. But if you have to do check the acid-base status, actually get the pH and all of that, and then you'll need to get a sample, an arterial sample, and run it by blood gas analyzer. And there are some physicians now that are also doing capillary samples for blood gases, and that's a possibility too. And these blood gas analyzers have also been upgraded to add additional analytes, including blood sodium, potassium, and chloride, because these can use different iron-specific electrodes, and it's pretty easy to add into that system. Some of the causes of acidosis and alkalosis in a newborn and in infants. So for metabolic acidosis, renal tubular bicarbonate wasting, so they're losing their bicarb. Therefore, then bicarb's a base, right? So then before they become acidic. Anoxia, so not enough oxygen or poor tissue perfusion, meaning poor tissue blood supply, which then means poor tissue oxygen supply, right? And so in both of those, you would get anaerobic metabolism to produce ATP, and you would get a lot of lactic acids produced, and that would lead into metabolic acidosis. And then various metabolic diseases. And then in respiratory alkalosis, the predominant one is going to be hyperventilation of the baby, whether they're hyperventilating by themselves or they're being hyperventilated because they're on a ventilator or something like that. Metabolic alkalosis, high blood ammonia, that would be from the immature liver. Metabolic diseases, pyloric stenosis, and so this is where there's a narrowing of the pylorus, which is the emptying of the stomach into the small intestine, right? Loss of gastric acids, and then excessive bicarb administration. So if they've given the baby too much bicarb, you overcorrect it. And low blood potassium are all causes of metabolic alkalosis. So let's look at the regulation of electrolytes in water. So the kidneys are critical for the maintenance of electrolytes in water. They control the rate of salt and water loss and retention. The glomeruli and renal tubules do not function at a normal rate at term, and they do not reach full potential until they are 2 years. So until then, they are very easily susceptible to dehydration and all that, which then can become a concern if you have nausea and vomiting, etc., for the infant or the young baby. You also have diminished filtration within the kidneys and impaired reabsorption of salt and water. So we're going to look at some of the four main ones here that can affect electrolyte and water balance. So we have hypernatremia, hyponatremia, hyperkalemia, and hypokalemia. So hypernatremia is high sodium, greater than 145 milliequivalents per liter. Causes are going to be hypotonic fluid loss, loss of water, especially, for example, due to the overhead heater in the newborn units to keep the baby warm, but then it also causes it to lose water by evaporation. GI loss, so if they're having diarrhea or vomiting, something like that. Fluid deprivation, they're not being fed adequately, or they're not eating. Nephrogenic diabetes insipidus, so there's where the kidneys possibly aren't working right and they're not retaining water the way they're supposed to. And excess sodium infusion, that would be in fluids, right, that have sodium in them. And hyponatremia, so sodium less than 130 milliequivalents per liter. The causes are going to be hypertonic fluid loss, a syndrome of inappropriate antidiuretic hormone secretion, hypertonic fluid administrations, renal tubular acidosis, salt losing, congenital adrenal hyperplasia, cystic fibrosis, diuretics, and renal failure. Hyperkalemia is a potassium that's greater than 6.5 milliequivalents per liter. It is caused by fluid deprivation, dehydration, intravascular hemolysis, trauma or tissue damage, acute renal failure, and salt losing, adrenal, not ADH, congenital adrenal hyperplasia. Sorry about that. That's actually a mistake right there. And then hypokalemia is potassium less than 3.5 milliequivalents per liter, caused by syndrome of inappropriate antidiuretic hormone secretion, diuretics, alkalosis, pyloric stenosis, renal tubular acidosis, secondary to bicarb loss are all the causes for our pediatrics. A little bit about liver function. So, physiologic jaundice, it results from the inability of newborn immature livers to adequately metabolize bilirubin, which is constantly being produced because red cells are being turned over every day, all day. So therefore it causes the serum bilirubin levels to increase and can go up to even 15 milligrams per deciliter, which is quite a bit. And if they get that high, it can lead to kernicterus and severe brain damage. So kernicterus is the accumulation of bilirubin in the brain. Bilirubin is fat soluble, so it really lacks the fatty tissue of the brains and stuff, and it can cause brain damage. So one of the ways to reduce the high unconjugated circulating bilirubin levels is the phototherapy with ultraviolet light. So it's called the Billy lights, and so they put them in a little incubator and shine the blue Billy light, and they usually cover their little eyes up so it doesn't damage their eyes and, you know, bother them and stuff. And yeah, a way to do it like at home would be to lay the baby in its diaper in sunlight also, but the Billy light actually does a really good job at doing it, especially if the infant has to be in ICU or in the newborn unit or something like that. The energy metabolism, so the conversion of galactose to glucose is impaired in some genetic deficiencies. Galactose is the sugar that's present in milk, right? And so then therefore it reduces the energy content of milk by half because it's half galactose, half glucose, right? And so, and if you can't convert to galactose, it can't use that as a sugar as a source of energy. And then gluconeogenesis as a conversion of alanine into glucose. So this is an amino acid, so a non-carbohydrate source into a carbohydrate into glucose. That pathway is not always mature at birth because this happens in the liver, obviously. And so that could lead to hypoglycemia if their glycogen stores become depleted. And the glycogen stores will become depleted if they're not eating, for example, and skipping feedings and stuff like that, and going too long between feedings. Diabetes, so it's a condition in which the endocrine control of glucose metabolism is abnormal, so the insulin regulatory pathway fails. There are two types of diabetes. Type 1 is the insulin-dependent one. It's a autoimmune disease. It is more common in pediatric patients, so the pediatric patients usually are developing type 1 diabetes. Used to be called juvenile onset diabetes, but it's no longer. It's just type 1 or insulin-dependent diabetes. And so with that, you have a destruction of the insulin-producing cells in the pancreas, and they have like no insulin present. So they cannot metabolize and use glucose, and therefore they will require insulin injections. Type 2 is non-insulin dependent. It's associated with an increased resistance to normally secreted insulin in obese individuals, and it becomes more prevalent among children now, unfortunately, because of the way our children are eating and what's in our diet and stuff like that. And so you've got some 4-year-olds that weigh 100 pounds and they're developing type 2 diabetes, which is, unfortunately a sad statement for our society. Hyperglycemia caused by diabetes should be distinguished from hyperglycemia from other medical causes, medical conditions. And so it's good, you have to investigate if there is hyperglycemia in a child. To be diagnosed with diabetes, you have to demonstrate one of the following diagnostic criteria. The child either has to have a fasting plasma glucose above 126 milligrams per DL, or a random plasma glucose that's above 200 milligrams per DL, or and that would be 2 hours, sorry, after a 75-gram oral glucose load, or just a random glucose over 200 also. And then symptoms of hyperglycemia, which would be polyuria, polyphagia, and polydipsia, meaning they are thirsty all the time, they're hungry all the time, and they're peeing all the time. And again, with the random plasma glucose is above or equal to 200 milligrams per DL. Or if you do a glycated hemoglobin A1C, anything greater than 6.5%. So a little bit on nitrogen metabolism. So the liver is obviously in charge of nitrogen metabolism, and so therefore high ammonia levels are common in newborns because of immaturity of the urea cycle enzymes and because of portal circulation. Again, bringing it connects the intestines to the liver. And then a little bit on nitrogenous end products. They can be used as markers. One of the markers is renal function, so how well the child clears the waste. And so for that, creatinine is in nitrogenous end product, and it's related to muscle mass. So levels of creatinine are always going to be lower in newborns, but then the concentration should increase as the muscle mass increases, independently of their diet. Other nitrogenous end products, such as blood, urea, and nitrogen, are dependent of diet. And so therefore creatinine can be used as a marker for glomerular filtration to assess the renal function in pediatric patients. The liver function test, the liver is responsible for performing a large number of synthetic and catabolic processes, so building and breaking down stuff. And normal liver function is central to maintaining body homeostasis because it makes a lot of stuff again, and it clears a lot of waste and stuff. And liver function tests usually include at least a serum albumin, usually it's total protein and albumin, total and conjugated bilirubin, and the liver enzymes, at least AST, ALT, and alkaline phosphatase. A little bit on calcium and bone metabolism. So normal bone growth will require the integration of calcium, phosphate, and magnesium metabolism to build the bone, to make it strong. And the endocrine regulation from vitamin D, parathyroid hormone, and calcitonin. So you need vitamin D to absorb calcium. And then parathyroid hormone is secreted to increase the blood calcium levels. And so therefore parathyroid hormone can take calcium from the bones and put it into the blood, right? It can also increase calcium absorption. And then calcitonin, if the child has adequate calcium intake, adequate vitamin D, and is absorbing the calcium, the calcitonin is going to make sure that that calcium gets put into the bones. And so there's abnormalities in any components that regulate calcium. They can have profound clinical effects on children. For example, if they're lacking vitamin D, they can get rickets, where they get the softening of the bone, they get these bowed legs and stuff. And so it's very important for all of those things to be adequate. Hypocalcemia and hypercalcemia. So hypocalcemia, the total serum calcium is less than 7 milligrams per DL, or the ionized calcium is less than 3 milligrams per DL. If they have hypocalcemia, you can see irritability, twitching, and seizures, and a prolonged hypocalcemia can then result in reduced bone growth and rickets. Hypercalcemia, the total serum calcium is going to be greater than 11.0 milligrams per DL. It is rare in pediatric patients, but patients that have hypercalcemia will have poor muscle tone, constipation, and failure to thrive, and can develop kidney stones that could lead to renal failure. So a little bit on the endocrine function. So let's look at the hypothalamic pituitary thyroid system. So the hypothalamus secretes thyrotropin releasing hormone, which is TRH. It goes through the portal blood system into the anterior pituitary, and then it causes the anterior pituitary to release thyroid stimulating hormone, which then goes to the thyroid and causes the thyroid to make and release T3 and T4, which then flows into the body and governs metabolism, energy production, growth, all kinds of things. And so there are two areas of dysfunction that are of concern to pediatric patients that could prevent the release of an adequate amount of thyroid hormone. There's primary hypothyroidism. It is a defect that causes a failure of the thyroid gland itself, and it will not synthesize and secrete the thyroid hormone. And this results in a common disease known as congenital hypothyroidism. It used to be called cretinism. and it is present in 1 of 4,000 births. It obviously can be treated by simply administering and giving thyroid hormone. Some of the effects, if not corrected, then you see facial abnormalities with a tongue, like, the jaw protruding and the tongue sticking out. There's an umbilical cord that sticks out. There's a failure of growth, and there's severe mental retardation, mental impairment, and it really, like, their mental development is stunted incredibly. And so it is really important that this is detected early. And so in primary hypothyroidism, usually what you see is a high TSH and then low T3 and T4 hormones. And there's also secondary hypothyroidism, and this is a failure of the pituitary gland to secrete TSH, which then will result in a lack of thyroid gland stimulation, and the thyroid gland that would normally function, and so therefore there would be low production of thyroid hormone because it is dependent on TSH. And so in secondary hypothyroidism, you would see low TSH, low T3, and low T4. So the hypothalamic pituitary adrenal cortex system, it is essential for regulating mineral and carbohydrate metabolism. It usually leads to the production of cortisol and all that which is necessary. Diseases will result either in hypofunction or hyperfunction of the system. There are quite a few hormones that can be affected, but the steroid 21-hydroxylase deficiency can result in a failure to adequately synthesize aldosterone and cortisol. It's just one of the deficiencies that can happen. And in growth factors, there are 2 hormones that are secreted by the hypothalamus that will affect growth. There's growth hormone releasing hormone and growth hormone inhibiting hormone, and of course then they affect the release of growth hormone from the pituitary. There are additional factors from the higher cerebral centers, the cerebral cortex, that include, for example, the presence of the catecholamines, that's your epinephrine, norepinephrine, dopamine, and all of that. Serotonin, ghrelin, which is the hunger hormone, and your endorphins. All of these have a positive effect on growth hormone secretion. So basically, ghrelin, the appetite one, they have to be hungry and eat, have this intake of calories and energy in order to grow, and apparently, so social deprivation in infants can inhibit that growth hormone secretion and stunt their growth. And so this is why children and infants especially need to be interacted with and be picked up. They need human interactions, and they see these in overcrowded orphanages where the infants are just laid in cribs and they're not like handled, or they don't have an interaction with a caregiver and stuff, that these children have stunted growth and problems with growth hormone secretion, and they really have problems thriving and stuff. They're not happy babies. And on the endocrine control of sexual maturation, the hypothalamus will secrete GnRH, which is gonadotropin releasing hormone. It causes a release of follicle stimulating hormone and luteinizing hormone. The baseline levels of the gonadotropins LH and FSH are very low in infants and in young children because of GnRH suppression. So FSH and LH have different effects in males and females, both before and during puberty. And so just quickly, just before puberty, obviously you have GnRH suppression, which then suppresses the production of testosterone, estrogen, progesterone, all that kind of stuff. But then at puberty, that suppression is stopped and you start getting GnRH released, and then puberty starts, and then you start having the release of testosterone in the males, which then causes increase in linear growth, increase in muscle mass, a deepening of the voice, sexual maturation, and all of these things. And then in the females, you have estrogen, progesterone releases and all of that, and then they'll start, having female curves, having growing breasts and stuff, and then they'll also start eventually starting the menstrual cycling and all of that. Usually the problems that you may be concerned with in pediatric patients is going to either be precocious puberties, meaning that there are, you can sometimes see the development of puberty as early as 4 years old, which is really crazy. That could be due to exposure to different chemicals and stuff like that, especially a lot of the endocrine disrupting chemicals, or then a delayed puberty where it's not happening and stuff. And lastly, the development of the immune system. You have neonatal and infant antibody production. So the human fetus is able to synthesize a small amount of IgM into a lesser degree IgA. IgG has a lower molecular weight than IgM, of course, and readily crosses the placenta. So antibodies from mom can cross over into the baby. And IgG can also be transferred from the mother to the baby in breast milk. So the mother's antibodies there are protecting the baby. And the breast milk also has IgA in it. The process of antibody production in infants will take several years to fully complete when you base it on the total serum levels of the different immunoglobulin subclasses, so the IgM, IgA, IgG, IgE, etc. And it can take up to 4 years to really attain full production of antibodies, which is again why they're more susceptible to infections and being sick and stuff like that. The disorders, pediatric disorders of immunity, we have the transient hypogammaglobulinemia, means that transient, short term, not enough of the gamma globulins, which are your antibodies. And so that could just be due to a delayed onset of these immunoglobulin productions, and you just don't know why. It just takes them a little bit for their immune system to start kicking in. And then you have agammaglobulinemia, where it's called Bruton's disease, and where you have no gamma globulin production. It's a complete absence of the gamma globulins, and occurs in boys and is an X-linked disorder, so their immune system is not good at all. And then another one where the immune system is not good is the severe combined immune deficiency, or SCID. In infants, they lack both humoral and cellular pathways for killing bacteria and viruses, and so these are very, very, very susceptible to everything that comes around. They don't usually live to be very old because of that. And genetic diseases, so the inheritance patterns of genetic diseases, you have autosomal recessive mode. You have 2 disease-causing mutations in a gene for the disorder to occur, usually one maternal and one paternal. You have recessive but inherited on the X chromosome, so then you only need 1 copy. And then you have dominance, inherited as a single mutation through either parent, and you only need 1 copy to get the disease. And then some are passed through mitochondrial DNA, and they would be inherited only through the mother because the mitochondria come from the egg, right? And then cystic fibrosis is an example of a genetic disease. It is one of the most commonly inherited genetic diseases in the pediatrics. The rate in the Western populations is in 1 in 2,400 live births, and it results from recessively inherited mutations in the CTFR gene, so it's an autosomal recessive. And the babies present with pancreatic insufficiencies and chronic infections of the lungs, etc. And a little bit on newborn screening for whole population. So obviously there we're looking for genetic diseases. They're looking for the most common ones. So we have phenylketonuria is the first genetic metabolic disorder that was screened for in every baby born in the Western world. It's PKU. Then they added 21-hydroxylase deficiency screening, sickle cell disease screening, congenital hypothyroidism screening, and galactosemia. And a lot of that is done by tandem mass spectrometry, which allows the screening of many different biochemical genetic diseases on a single sample at the same time. And there are, if you want to diagnose it in a clinical setting, so this is past the newborn screening, there are 2 main types of genetic metabolic disorders, the ones with large molecules and small molecules. So the large molecule diseases have an accumulating intermediate of metabolism that comprises a large complex molecules. Many involve intracellular accumulation of these molecules of these abnormal chemicals, and there's very little excretion in the body fluids. But with the small molecule diseases, they result from a defect in a metabolic pathway of intermediary metabolism of that molecule, and usually these feature low molecular weight compounds that are readily excreted in body fluids, and then you can pick them up, for example, in a urine or in blood. And drug metabolism and pharmacokinetics for the pediatric patients. So infants and children will handle pharmacological agents significantly different ways than adults. So there are factors that affect drug metabolism, such as absorption. A lot of the pediatric medications are in syrup. forms versus tablets, especially for infants and all that, because you cannot get infants to take pills. You may get some children to take pills, but a lot of times it's just easier to get them to take a syrup. And then they have less acidic gastric secretions, so that can affect also, for example, if it, how it metabolizes or interacts with the drug. And then for the circulation and distribution, children and infants have less adipose tissue, and that can affect the lipid-soluble drugs. And with the metabolism and clearance, they're immature hepatic metabolism. So again, we just already discussed the liver is not working full on already, and so that could affect, of course, the clearing of many drugs in infants. So last therapeutic drug monitoring. So the principles remain the same in adult and pediatric clinical chemistry. It is important to measure blood levels of drugs to guide optimal dosing, especially with a drug with well-defined therapeutic index, such as maybe a seizure drug like phenytoin. And some of the toxicology issues in pediatric clinical chemistry, the children who unknowingly consume pharmacologic and other chemical agents in the home are one concern. So they find some pills, they see mom or dad taking the pills, and they're like, well, I'll just take some of those too. And then, or they think it's candy and they eat them and stuff like that. And then, of course, you have in older children and teenagers, you have self-ingestion of street drugs. This can start as early as in middle school. And then a rare but potentially dangerous condition for children is that of Munchausen syndrome, especially Munchausen by proxy. Because Munchausen is self-harm, Munchausen by proxy is harm of others. In this condition, the mental illness of a caregiver, like a mother or father, causes them to give unnecessary and illness-causing drugs to an otherwise well child. It's usually portrayed in women, so I'm not sure if men get it, but anyway, Munchausen by proxy, they're harming their child for the attention it gets and stuff. So, and that is it for pediatrics. Thank you for your attention in this long presentation.